Hey, I'm Sarah Smith, family doctor, clinical day advisor, and the chatting coach. Welcome back to Sustainable Clinical Medicine podcast, where we're going to be interviewing peers or world experts who can help us think about our clinical day in a way that is more sustainable and create time for our lives outside of medicine. Hi, and welcome everybody. Today we have with us Dr. Bertina Hooks. Hello.
Hello, how are you, Sarah? Nice to
Good.
meet you.
Nice to meet you too. We're excited to have you today. Tell us a bit about you.
So, my name is Bertina Hooks. I'm a board certified internal medicine physician. I now live and practice in Texas, but I initially practiced as a hospitalist for over 10 to 15 years and across multiple states. I worked as an employed hospitalist and then started doing locums and then eventually have my own practice. So I did my own private practice and also worked employed as an outpatient doctor as well. So lots of different experiences over the years. Happy to be here.
Yeah, wonderful. Tell us about your career, that journey through medicine. What was going well? What did you notice about working in that hospitalist environment? Why did you like that environment specifically?
I always liked hospitalist medicine when I was doing my residency training.
Mhm.
So I loved the inpatient side. I think it's just higher acuity, a chance to really help people when they really have emergencies or like having a stroke or a heart attack, being in heart failure. And I loved the way that the hospital works. Just that working with different multidisciplinary teams, working with patients and families and other consultants. I just always loved the inpatient setting. So that's why I chose hospitalist medicine. And I really enjoy it. I still love it today. And then I kind of transitioned a little bit into outpatient medicine just because as I got older and then I also had other responsibilities, I had a family. So
Mhm.
working in the outpatient setting was great for me just because I could have a balance of home and life work balance a little bit more instead of working longer shifts in the hospital. But what I love about medicine is that you can, I guess, you can tailor your practice to what you want, depending on what stage of life you in or what you
Mm.
desire or what your needs are. I think your medical career is not linear and you define what it is. Yes.
Yeah, it can feel very much like a trap. You don't necessarily know that you have choice when you are
Yes.
working within an environment. I see a lot of this where physicians will be somewhere and they're not having a good time or they're not respected or it really
Mhm.
isn't fitting with their lifestyle anymore. That's what they've trained to do. It's
Exactly.
really tricky to start to imagine what life
Mhm.
looks like beyond this team or this environment.
Definitely. And so late now in my career, I actually do more non-clinical. I do a little bit of a hybrid, which is
Mhm.
rare. People don't do that. So I do clinical medicine. I have my own outpatient practice. I do PRN shifts as a hospitalist because I'll never not love hospitalist work. And then I also do non-clinical work. So I do utilization management, I do medical expert work and consulting. So I feel like I have the best of both worlds because I have a little bit of clinical and non-clinical.
What does utilization management look like? What is that?
So basically, it's like utilizing your medical degree. You can work for an insurance company or a hospital system and basically review charts. You do case reviews and determine does the care meet medical necessity for inpatient level of care, or is it medically necessary to have an imaging test or some DME that's been ordered? So any order or request by a provider or physician goes to an insurance company, also may go to the healthcare plan and determine if it is medically needed. And so
Mm.
then you have to provide rationale reason why it is or isn't so that patients can get the right level of care at the right time for their needs.
That's pushing into some area that some physicians are really unhappy about, that they
Yes.
have to justify care. They
Yes.
are sitting there as the expert of most responsible physician for this patient. They want
Mhm.
this, and now they have to argue for it.
And I think that not all of the work that I do is peer to peers, but some of it is where I do have to have discussions with other physicians. But I think a lot of times the peer to peers are pretty collegial because it is a peer-to-peer. It is one provider speaking to another provider. And you'll be surprised. There's a lot of things that go into how we practice medicine. Some of it's population health, like where we practice the culture of the area that we live in and things like that. And sometimes we just feel strongly. Maybe we don't have evidence to support or back why this is needed, but it may be medically necessary depending on the circumstance. Just depending on your training or your background or your experience with this particular thing. Not everything is textbook. So it's
Hmm.
nice to have those discussions with other physicians and learn about different specialties and things like that. So it definitely has broadened my comfortability with things that are maybe outside of my scope of practice. So that's a
Hmm.
good thing.
Yeah. Tell us about outpatient medicine and how did it get contained to work hours? Were you able to
Mhm.
do that or was it spilling into your evenings? Tell us more about the outpatient experience.
I'll tell you that in residency, one of the things I didn't like about my outpatient clinic was that you have to stay back and chart and finish all your notes and things like that. Same thing in hospitalist medicine as well. But when I started my own outpatient practice, I had been practicing for like 5 or 6 years as a hospitalist. And so when I started my own practice, I really wanted to make things sustainable for me because I was pretty much the only provider taking care of my patients. And I inherited a practice from a physician who was retiring. So I kind of really thought, I was really intentional about the systems and the workflows I had. So I tried to be very intentional about how things are scheduled, so I had adequate time. I always would try to do huddles with my staff before the morning patients and then an afternoon patient. So we get a plan of care. Sometimes patients would schedule something, but maybe we didn't get a lot of information. So I would have my nurse triage it. Or for instance, I would have somebody who would just like maybe schedule to see me in the afternoon, but we didn't know what it was. So we would huddle, we would talk about what could this patient need? Why don't you reach out to them? One example I can give is a patient who had fallen and they made an urgent appointment to see me and they were also on Coumadin. So we were concerned about a fracture, obviously.
Hmm.
So when the nurse called and kind of got a better sense of what they needed, we would preemptively order x-rays and labs and things like that. And then I maybe would have the nurse call the ortho clinic down the hallway and say, hey, or down the street and say, could you see this patient? I think they may have a fracture. We're getting x-rays or maybe first thing tomorrow so that there's not any delay in care. Also, I always had patients do their labs before they came in. So a week before, I would say, okay, make sure you get your lab work done so that I could review it. So then I could optimize talking about results, but then also talking about plans of care and things like that. I think with the charting, I use scribes, I've used in-person scribes, AI scribes. I have used other templates and things like that before scribes were in vogue. But I think you have to be intentional because I think efficiency matters, but I also think being intentional with how you practice medicine and making sure you put systems in place. I would try to delegate things to my nurse or medical assistant that they could do, even like when you have to do your inbox of labs, all the normal things, I would have templates that they could send, but if something was abnormal or flagged as abnormal, they would have to come to me and then I would interpret those. So that allows a physician to utilize their degree at the level that they're supposed to interpret, to diagnose, to treat, and discuss those things that only a physician can really take care of. Yeah.
Those skills of delegation and team collaboration, that probably wasn't at the resident outpatient clinic to the same degree. Where do
No,
you
it
think
was.
that pulled from? What do you think helped you to harness those sets, or where did you learn them?
I think I learned them as being a hospitalist when I first came out into practice, even though it was in the inpatient setting. I had a workflow, even though I didn't have defined patient appointments. I designed a way of how worked best for me in the first 5 years of practice of how I wanted to practice. So I would always preemptively look at charts before I went to round. And a lot of times I rounded at different hospitals, so I had to be very efficient. I was fortunate that when I was employed as a hospitalist, a lot of times I had mid-level support, so I feel like delegating and utilizing mid-level support is very important. I would delegate to them for maybe seeing possible discharges for that day. So like the lower acuity or maybe doing admissions and staffing it with them to make sure that the plan of care was adequate and discussing the plan of care with them once we saw the patient together. And then after I preemptively looked at charts and labs and things like that, nursing notes, consult notes, things like that, then I would start with the higher acuity patients, like in the ICU and things like that, and then move my way on to maybe my admission. So in the hospital, we had to prioritize admissions for workflow for the ED so that patients would be discharged by 9. So that made me realize that you have to be really intentional how you practice medicine, because any type of medicine, whether it's inpatient or outpatient, is really demanding, right? There's going to be emergencies, things that come up that you need to handle. And so having efficient workflows, I think. And so when I started my own practice, I thought about the things that worked for me and worked in my previous practice, whether it was in residency or employed situations, and said, what would be the best way for me to practice medicine and help me take care of my patients safely, effectively, things like that. So that's what I really spent time, so to speak, thinking about that and being intentional and creating those policies and procedures myself. So I think
Mm.
that's what went into it.
Taking on somebody else's patients, they've been
Yes.
worked in a different, potentially different style than you. That can be really
Mm-hmm.
challenging to
It
take on
can be.
somebody else's patient panel. How did you navigate that?
I think the culture of the previous practice was different than the culture I was trying to establish. And the practice I inherited, for better for worse, was the patients didn't, they would come by for emergencies. It was kind of emergency care. They were high utilization of resources in the ER urgent care. So we tried to, once the transition from their practice to my practice, I tried to establish what the culture is here, what the policies and rules are. But we still had a lot of patients that would show up unannounced and say, I'm out of my meds, or I need this or that. And so we would just redirect them towards, this is the way, we need this amount of time to handle your requests. And we're happy to take care of it now, but in the future, you're going to have to follow our policies and rules. And so some patients fell in line with that, and some patients
Mhm.
didn't. And so I think you have to create that culture and that practice policies and procedures so that everyone's able to get the same amount of care effectively and efficiently. We love to take care of patients, obviously, but we have to prioritize things and triage things, obviously, based on what is more important. And sometimes most patients fell in line with that. They like that. They like that I was going to see them regularly and that they weren't going to have to go to the urgent care or to the ER because that's a higher copay. They wanted to see me. So establishing those rules and that culture, I think, really set the precedent for my practice. And it grew. I grew in a year or two. I grew to 3 different locations in the northern Sacramento area. And I think that was due to the fact that we really tried to take care of patients in an efficient way, and we established things that patients knew that we were going to address their issues as long as they were handled in the right way.
Was that you the only physician working in those three practices, or did you hire other doctors to help you? How did
I
that work?
did hire other providers to help me in the office
Mm-hmm.
eventually. So the first location I was just by myself. And then obviously as things expanded and grew, then I did hire other people. And I also hired an office manager to help me manage things and coordinate things between the different locations. They weren't very far away, and so I could go and see patients at other facilities. I would make myself available certain days of the week, but I did bring on other physicians. And you have to be like-minded as well when you bring on partners into a practice. So I was very intentional about bringing people in that not necessarily have to practice like me, but are similar minded on how their philosophies on patient care.
Yeah, interesting. And not just patient care, because it sounds like you'd set up a model of care. And so you could
Mhm.
have a physician coming in with similar ideas, but they aren't used to having somebody else check their in basket for them like you. That can
Mhm.
be very intimidating for physicians who haven't ever had someone address that, even the normal thing.
And initially, I think there was a little bit like, why is the nurse or the medical assistant like in my inbox? But then they realized that that could free them up to do other things like prior auths or doing peer-to-peers or other things that only they as physicians could do. And they started to understand and they actually liked it. But yeah, it's something that's different. It's a different concept that most physicians may not apply in practice.
Did you do any onboarding or teaching training about that for the physicians or providers that you hired?
Yes, I did. And I definitely, before the providers came on board, I also onboarded my staff. I really wanted my staff to be invested in the patient experience. That's one thing we talked about, etiquette and things like that. But when I brought providers on, yes, I did do onboarding and said, this is the way I practice so that they would be understanding. And so I told them up front when we were talking about the position and if they felt that they were an appropriate fit. But I did have an onboarding process where we talked about you don't have to manage all this in your inbox yourself. We want you to use your degree to the highest level. We want you to manage things that you feel comfortable with and that if you have questions, we're here. It's like you can ask a colleague. You don't have to feel limited. The office space that I was in was shared with some specialists as well. So we had a specialty group that we could bounce things off of, talk about things so that was nice. It was a very collegial kind of environment.
You said you hired a practice manager. I know that the business side of starting a practice can be really uphill. It's a
Yes.
set of skills that you don't learn in medicine. The balancing accounts, ordering stock, stocking your
Yes.
rooms, having
Yes.
appointments, having an EMR, and managing all of the pieces that
Mhm.
go with a business. Where did you do that training, or how did you get your head around that? Where would you fit that into your week?
So I had admin time blocked off. I tried to have some hours of admin time throughout the week. I think that's important. And
Hmm.
so before I had even a medical assistant, when my practice was very small, I took the labs. Sometimes I would check in the patient. I did have a front desk person that helped, but when the practice was really growing, I did a lot of the hands-on things. And I really learned a lot about the business side of medicine, which I agree you don't really learn in your training. And so I learned about accounts receivable and billing and inventory and things like that. I was the one managing it. So when I brought on a practice manager, I really wanted someone to have that experience and understand how my practice ran. And so I could hand off some of that responsibility to them. I did a lot of the onboarding and training of my medical assistants. One of the things I did was I was a preceptorship site for medical assistants. And so I would bring medical assistants in. They could get 6 weeks of training experience, and then that would be an on the job like interview. And so maybe I would select some of those medical assistants to bring them on as needs occurred. And my office manager really was someone who had a lot of I think it pays to have someone who has a lot of experience with the business operations of medicine, things that we don't even think about. Like, how do you coordinate consults and referrals? How do you get those reports and things back so that I can review them? Those are the things that you have to troubleshoot as a practice that people don't realize if you're not employed, you're the person who handles that. So
Mm.
that really was something that I feel like I'm an entrepreneur and that awakened the entrepreneur spirit in me, like learning about marketing and advertising and financing and all of that. I really learned on the job, so to speak, and networking with other people and having great mentors about the business operations of a practice, for sure.
Yeah. And you said that transition was around the time that you were beginning to be a mom, is that right?
Yes, so I had my daughter in 2012. And so I had just finished residency at that time. It had started as an attending. And so as my daughter became older, when she was like a toddler, maybe I started to say, I probably need to be home more. For a while, I was a nocturnist as a hospitalist. So that was good because I could be home during the day with my daughter and I worked at night. But as she got older and became of school age, elementary school age, I really wanted to be home more. So having my own practice gave me a lot of autonomy, a lot of freedom, and so I could be there for pickups, drop-offs for school activities, which I really enjoyed.
And that's a lot of work because you're not just being
Yes,
doctor, you're also being businesswoman and mom.
yes, yes, yes. But it was very fulfilling. I felt like I was really growing and evolving. So I really enjoyed that time. It didn't feel like work because I felt like I was practicing medicine really on my own terms, and it was very sustainable for me. Yeah.
Yeah, that's really
Yes.
perfect. It's great that you were able to find that one intention about what you needed. And you
Mm-hmm.
kept asking yourself that question, what do I need? I need to be home now during the day. I need to
Mm-hmm.
have this contained to the work hours. I need to have admin time during the day. So I'm not going to do this in the
Right.
evenings. I hear that intention kind of woven through all of that planning for that
Mhm.
business.
Yes. Yes.
I don't always see that, which is important because I think that we take ourselves out of one trap and end up in another trap of our own making. It
Yes.
can be very disheartening.
Yes. And one of the reasons why I was able to make that leap and make that attention was I did a hybrid. I started my practice, but I was still working as a hospitalist. So I only worked so many, like I worked so many days a week as a hospitalist, and that helped fund my practice. And then I would be available for my patients the other time of the month. So it was a good hybrid. So I was able to ramp up my practice slowly and be really intentional. I had to do all the credentialing, all of those things that you have to do before you start. So it allowed me to ramp up and then start my practice when I was ready, really ready and
Hmm.
prepared.
Okay, what are you doing now? Because you're working with some physicians now, you're doing moved into some of that coaching or mentorship space. Tell us
Mhm.
about the transition to that and what you found.
Yeah, so I became a physician coach after the pandemic. After the pandemic, I really was experiencing a lot of burnout, and I realized that I needed to maybe pivot or transition, take a step back from clinical medicine for a little bit, especially after the pandemic. So unfortunately in 2020, December 2022, I actually had a serious health condition, a health emergency. I was hospitalized, and I ended up having strep necrotizing fasciitis, a
Mm,
serious infection. I ended up having to have an emergent right below the knee amputation.
wow.
So, because of that, I really had to step back and really be intentional at that time and say, what do I want from medicine? What I've really invested my whole life into medicine and I enjoy it, but my family, my health is a priority, and I needed to step back and figure out what I wanted to do. And I didn't want other physicians to go through the same thing. And I knew that other physicians were dealing with burnout and things like that. So that is what really prompted me to create Pinnacle Business Academy, which is my physician coaching. So I deal with burnout recovery, career clarity, and reinvention. So if physicians are saying, I've done everything that I want to do in my medical career, what's next? Or what are the other options that I have outside of clinical medicine? Or how can I redesign how I practice medicine? So I talk about clinical alternatives, maybe locums, maybe DPC, or which I've done as well, and concierge medicine. I talk about help them decide if they're interested in maybe doing telemedicine because telehealth is really became bigger during that time. I also
Mm.
talk to them about non-clinical pathways because I've explored it all. I especially explored it during that time. So utilization management, which I do currently, medical expert work and consulting, and then pharma, biotech are the main three ones, top three careers that most physicians are interested in. And so I provide peer coaching, group coaching. I provide intensives that are more one-on-one with small cohorts where I really help them help them figure out how do you recognize the signals of burnout, do a burnout assessment. What do you do now that you realize that you're burnout? How do you do that recovery process and start a 90-day plan towards recovery? And then once you start dealing with burnout, then you can really start getting clarity about your career and what you want, what your career identity is, and then where do you want to strategically position yourself? Do you want to do leadership? Do you want to do entrepreneurship? Really, the sky is the limit. And I just help physicians explore those career options and help guide them so that if they want to pivot, they can. The options are there. And really, it's all about mindset because you have all the transferable skills as a practicing clinician. You're just applying it in a different way. And so that's the beauty of it is that a lot of people feel like I have to get certificates or other degrees. No, your medical degree is enough. And that is just a different mindset, how you're applying it, your medical skills, and how your mindset towards it. That's all that matters.
Interesting, yeah. Is it always burnout that triggers a transition, or have you seen physicians or clinicians coming to you because they want to transition, but they're not seeing that as a
Yes.
universal reason why people decide to make big shifts?
I think burnout is one reason, but it's not the only reason. It could be changes in your life, like maybe you have a milestone, maybe you're a parent now, or you're a spouse, maybe you're a caregiver for a loved one and you want to transition, your priorities change. It could be disability, which was one of my reasons why 3.1% of physicians are disabled. And a lot of physicians who are disabled are being told by the medical community that they're not capable. But capacity is not necessarily this. You still have your medical degree, your training, your skills, and that can be utilized whether you are disabled or not. But I just want to my goal is whatever the reason that you are considering a pivot or a change in your career reinvention, you're doing it because you want to and you have the tools and the options that you can look at in front of you. That's the most important thing.
Yeah. The three non-clinical areas that you said, we explored one of them. Tell me about the other ones, the medical expert and the farmer. What have you noticed about those careers? What were advantages? What was it
Mhm.
like? That sort of thing.
I'll talk about medical expert work first, which I'm still currently doing in consulting. So that's pretty not too hard to do. You basically still have to do a business entity or structure, I think, to make it. And it's something that takes a while to build a rapport in the community because now you're in the legal community instead of the medical community. So you're interacting with lawyers and patients and other people like that. But the main thing with medical expert work is that you are an expert who's explaining medical terminology, terms, things like that to lay people. So that may be attorneys, judges, juries, patient families. And you can either work on the plaintiff side or the defendant side. A lot of cases don't really go to trial. I would say 90% of cases are settled, but you're utilizing your medical expertise when an attorney comes to you that say, is there causation? Is there some kind of negligence or, breach of what they call the 4 Ds? So basically duty, diligence, things like that. If there is some kind of breach of that, then that may be awarded damages or things like that. But in most cases, there's not a lot of causation there. And that's what you're being asked as a medical expert to make a determination. So you're using all of your medical training and knowledge and experience taking care of patients doing that. And it's very, at first I thought I'm not defending doctors, but actually a lot of the work that I do does defend doctors and help them. It helps them determine, hey, this is not deviation from standard of the care. This is not, they didn't cause this. There was other factors that, but I can't really pinpoint exactly what it is, but it wasn't specifically due to what this physician did. Sometimes bad things happen to good people, right? Sometimes bad outcomes happen even with the right intentions. And so I feel that the medical expert work is very worrying. One reason why a lot of people don't go into medical expert work is they have that misconception that it's about suing doctors but a lot of times the work I do protects doctors and it gives them a voice and says, no, this is not against the standard deviation of care. This is not caused by their negligence or anything. They wasn't in negligent care. And so I think and then also it takes some time to get into the medical expert witness field because you have to build credibility and rapport with other attorneys in the legal system. And you also have to be an actively practicing clinician. So this is not something you can do when you're retired or something like that, but it's something when you're actively practicing and taking care of patients. And so it takes a while. It's taken me years to build my medical expert and consulting business just because word of mouth and referrals and things like that. And so some physicians may not like that because it's a lot of work that has to be put into it, but I think it's worth it in the long run. As far as the pharma and biotech, I ventured into that because it is a lot of research based with drugs and medical devices and things like that. But I don't do pharma currently right now, but it was something I definitely explored and looked into. And having a medical degree, you definitely can work in pharma, helping develop drugs, medical devices, making sure they're safe and things like that. You don't have to have a PharmD or PhD to do that. The teams are mostly multidisciplinary, so you're working on maybe a drug trial or looking at this efficacy of a certain device, and that takes years to develop. So you're looking at different things and you're using your medical expertise along with the expertise from the other experts on the team on how to make the drug or the device the most effective. And so it's very rewarding work because you're making gains in on the cutting edge of healthcare, like breast cancer research and things like that. And so most people who are involved in pharma, it's very it's a lot of remote work. Sometimes you do travel, but it's a very nice lifestyle as well, but you're still utilizing your medical degree.
Yeah. So I'm seeing that imagination of what am I having trouble with right now? What am I looking for as an alternative? What other choices do I have that we can create new, different, kind of the exploration of
Yes,
choice? Yeah.
yes, yeah.
Can be so
And I think
diverse.
options are important. Yeah, it's good to have
Hmm.
options, right? I think having a diversification of it makes you realize that you don't rely just on medicine only, you rely on other things that may be tied to medicine, or you can pursue and do things that are in entrepreneurship, real estate, things like that, because you have that bandwidth. Yeah,
Yeah.
yeah.
Tell me about burnout. What are you noticing about physicians who are coming to you with burnout? What are some of the signs that they're coming or
Mhm.
identifying in themselves about burnout? And what does that path of recovery start to look like?
So I think a lot of physicians who come to me with burnout, sometimes the signs are subtle, but sometimes if it's more severe burnout, because it's a kind of a spectrum, right? So the first signs of burnout may be that you're emotionally or physically exhausted. If you take a break or you go on a vacation, you come back usually refreshed, right, to take care of patients again. But when you come back from a vacation or a break and you're not feeling that same excitement or passion or motivation, that may be a sign of burnout. If you're having apathy, if you're feeling sometimes even like feeling the burden from administrative tasks or things like that can lead to burnout. And so you have to recognize those symptoms early because the sooner you recognize those signals and you can get attention to that, the better off you can be to put in basically resiliency techniques. That's the whole thing. So you have to start working on self-care, maybe setting boundaries, delegating, as I've talked about. All of these things are part of the pathway to burnout recovery because you're putting skills in place that will make you more resilient because the stressors of medicine are going to be there irregardless, but it's
Mm,
how you adapt to those stressors and what kind of resources and tools you put in there. So I give them a toolkit, so to speak, to deal with that. So mindfulness techniques, gratitude, journaling, deep breathing, all of these things can help you during your day to stay mindful, to be centered, and to minimize burnout. And one of the things I think most physicians have a problem with is setting boundaries and delegating. I think those are the two biggest tools that when you learn that, in addition to self-care, obviously, getting adequate sleep, exercise, nutrition, things like that, are the biggest limiting factors. People don't want to say no. We want to say yes to everything, but sometimes in saying no, you're setting yourself up for success and you're saying to yourself, I care about what are my needs and values. And I think one of the biggest things that I teach is about a values energy audit. So what because your values define who you are. And when you are aligned with your values, that's going to be more sustainable. Where do you want to put your energy into? What do you value most? And when you're aligning your career with those energies and those values, that is going to set you up for a sustainable career because you're always asking yourself, what does this serve? If I take on this role in this committee or I take on a role at another facility, how does that serve me? You're asking those questions before you say yes.
yeah, absolutely. How do people find you if they're wanting to reach out and work with you?
They can reach out to me on social media. I'm on Facebook and Instagram, Bertina Hooks. I'm also on LinkedIn at Bertina Hooks. And then my coaching academy, Pinnacle Business Academy, is also on social media, Pinnacle Business Academy, and the website is pinnaclebusinessacademy.org, and it has all the information on how to book a clarity call with me, or to set up coaching, or sign up for any of the intensives.
Love that. What have we not talked about that we should be talking about?
So one other thing I'm excited about is that I'm going to be releasing my memoir. I kind of talked a little bit
Mm,
about my life and what led me to where I am now in my career. And I wrote that triggered me to write a memoir because I really felt that my life and the lessons I've learned would resonate with other physicians, because although we have differences, how we all have dealt with burnout, identity, and other issues. And so I felt that writing my memoir would resonate with and help a lot of people, especially professionals, healthcare workers, physicians that were dealing with the same things I was doing, being a parent, going through a divorce, going through hard times, and learning how to become resilient and overcome burnout. And so my memoir is called From Fire to Freedom, a memoir of transformation, renewal, and resilience. It's going to be launched September 23rd,
wow.
2026.
There we go.
And so if you're interested in learning more about me or my book, you can go to my website.org, and there's information about my book. You can sign up to learn more about when it's launched, be a part of the ARC Advanced Reading Copy team so you can get an advanced copy, give me a review, tell me what you like about the book, and you can also purchase it. It'll be on pre-sale on Amazon and on my website in August, but available on all platforms September 23rd.
That's very exciting. I like
Thank you. I'm so excited about it. It's been a labor
Congratulations. It's
of
a lot of
love.
work. That's right.
Yes, yes.
Labor of love indeed. All right. Now, for those physicians, clinicians who are listening in, who are feeling the pull of burnout and overwhelm and stuckness, what sort of message do you want to leave with them today?
I want to tell them that you need to give yourself permission to evolve. You are not stuck. You are not broken. You just need clarity about what you are looking for in your life. And so if you're looking for help with getting that clarity, I'm here to help. And I look forward to sharing more with you.
I love that. Thank you so much for this conversation, Bettina.
Thank you so much. It was a pleasure.
I love your energy and that ability to imagine beyond where we are right now and that we have choice where we are. It's so good. So thank you.
Yes. Thank you. Thank
And have a
you.
wonderful week, everyone. See you next time.
Hey, if you found this podcast episode helpful, I would encourage you to like and subscribe. Every time you do, you help a colleague or friend find our podcast, and it can help them too. Don't forget to share it along with your friends. If you're looking for extra help, don't forget we have charting champions for physicians and smarter charting for nurse practitioners and other clinicians to help you get home with your work done. We are helping you create sustainable clinical medicine. Thanks for listening.